for Masvingo province. Mr. Mzulu meets the editors, station managers, or their proxies from various media houses across the country, Harare, Bulawayo, Mutare, and then Masvingo. These ones you know.
Okay.
Thank you. And start by giving us the provincial status regarding the response to HIV and AIDS.
Okay, thank you, ladies and gentlemen. Welcome to Masvingo Province, National AIDS Council Provincial Office. As mentioned by Jadiwa, my name is Muzulu Edgar. Muzulu is M-U-Z-U-L-U. M-U-Z-U-L-U. I would like to welcome you to the National AIDS Council Office. I will outline the provincial status for HIV as it is, then I will entertain questions if there are any questions that will be required. Let me start with the provincial census for Masvingo. We have about 1,486,604 people according to the 2012 census, and we are bordered by Manicaland, Matabeleland provinces, as well as Midlands. In terms of HIV and AIDS, we have key drivers of HIV in the province, and these include multiple concurrent partnerships, low risk perception. We also have low condom use, especially in long-term relations. We also have low levels of male circumcision in the province, as well as age mixing, which also relates to intergenerational sex, with the old men especially having relationships with the young girls, especially in the urban setting. We also have transactional sex, which is very rampant throughout the province. Our hotspots where major infections come from, Masvingo urban is one such hotspot, accounting for quite a number of STI infections. We also have Gerera Growth Point in Zaka, where we have a problem of young girls selling sex. We also have the Chibi turnoff in Chibi district, as well as Ngundu. Ngundu is also in Chibi district. Then we have Chirezi district, also accounting for quite a number of these STIs. For your information, STIs are a proxy to HIV infection. If one gets an STI, it provides an ease entry for HIV. So we are worried by the number of STIs that continue to be recorded within our health institutions. In Chirezi, we have another contributing factor, which is the reopening of a very big beer hall called Chigarapas. And there we have a number of sex workers coming from all over the country, from Bulawayo, from Gweru, plying their trade, because there are so many workers in Chirezi working at Hippo Valley and also Triangle sugar plantations. And these provide a ready market for these sex workers. In sex work, we have different charges for sex. Protected sex is normally cheaper, unlike unprotected sex. So if a client offers more, it results in somebody agreeing that we can have unprotected sex. Unfortunately, that also leads to STIs. Then in terms of prevalence for the province, we have 12.8%. That's the HIV prevalence rate. That is, out of every 100 people, we have an average of about 12 people living with HIV. In terms of the HIV burden, we have Chirezi district, we have Chivi district also having the highest prevalence rate at 14.6%, and the Bikita district recording the lowest at 11%. Then in terms of number of people living with HIV, the absolute figures, by end of the third quarter this year, when we say third quarter, by the end of September, we had about 138,208 people living with HIV. And out of these, we had 9,700 being children. We also have, these are the children we are having in terms of clients on art. Then in terms of interventions, the National AIDS Council is focusing more. The National AIDS Council is focusing more on prevention. Our mandate is to generate demand for HIV services. So we focus mainly on 5 pillars of prevention. And these 5 pillars are: 1, adolescents, girls, and young women is the first pillar. We are saying the burden on adolescents, girls, and young women is been seen to be great in terms of research done, in terms of evidence on the ground. So that these young women, we need to do something. So we have a number of interventions for the young girls. We have what we call the sister-to-sister program. The sister-to-sister program is a peer-led intervention where we have mentors, young girls trained in sexual reproductive health and other health-related issues, so that they are able to impart this information to their peers. The sister-to-sister program recruits vulnerable girls in communities. When we say vulnerable, we mean those who may be orphaned, we mean those in from broken homes, and those in child-led homes. So we need to empower them. We need to empower them with financial skills. We need to empower them with sexual awareness issues. We need to empower them on economic empowerment. So these interventions revolve around those issues. Then for the adolescents, girls, and young women, again, we have young people in tertiary institutions. Masvingo is blessed to have many universities. We have Great Zimbabwe University. We have the Reformed Church of Zimbabwe University. We also have a number of colleges like Morgan State Teachers College, Bondorf Teachers College, Masvingo Teachers College. So many activities happen there within these institutions, especially transactional sex. And reports from our partners like SESHA and Population Services International indicate increased utilization of what is commonly known as the morning after pill by these young girls. These are the figures we are getting from our partners. So we are worried that the morning after pill, normally these girls seem to be more afraid of pregnancy rather than HIV. Because if you are taking a morning after pill, it means you have had unprotected sex, but not mindful that unprotected sex also causes HIV infection. So in that regard, we are also having interventions for youth in tertiary institutions. We are working with these universities, and we've got a task force made up of lecturers from all the universities, and we meet every quarter to review what is being done there. For 2018 and before, we used to have interventions such as dialogues, orientation for the youth, and other one-off activities. Then that is that for the first pillar, adolescents, girls, and young women. Then we also have VMMC as the second pillar for prevention. Voluntary medical circumcision is known to reduce HIV infection by up to 60%. And this is an effective intervention. However, it is not 100%. So we are working together with other partners like PSI to do VMMC in the province. We also have the traditional VMMC, which is done by the Waremba in Mwenezi district and also in Chirezi, and we support that. Normally, I'm sure some of us here have gone with us there for their graduation. This practice is done in Chirezi and Mwenezi normally, but we have succeeded in convincing them to adopt modern male circumcision, not the traditional way of using, maybe one blade for many clients, but now they engage Ministry of Health personnel so that they do the surgical issue instead of them using their own traditional people. As a result, we've improved on their hygiene and also avoid adverse effects for the clients. So that is to do with VMMC. Then we also have key populations as the third pillar for HIV prevention. Key populations refer to those sub-population groups like sex workers, like truck drivers, like artisanal miners, those sub-population who are hard to reach, who may be sleeping when interventions, because you find that the National Health Council and its partners normally implement these programs during the day, but there are certain people who will be asleep during the day, and these include these sex workers who operate during the night. We also have truck drivers also traveling long distances. So the key populations interventions we have include provision of condoms, the condomize campaign. We are making use of the sex workers themselves to distribute the condoms. We also have condom dispensers, which we acquired, which we procured as the National AIDS Council, and we've put them in strategic places where they are easily accessible to whoever wants to use them. But of course, the number of condoms distributed is not to our satisfaction. We faced some logistical problems with the present distribution system, but everything is now in order. We expect more condoms to be distributed so that the condomize campaign can actually be more effective. So that is to do with the key populations. Then we also have the condom programming itself as a key pillar as well. Number 4. So the condomize campaign, or increased use of condoms, is meant to prevent HIV infection. You can have a VMMC, but without a condom, there is no guarantee that HIV will be protected. So the best method for those who cannot abstain is to use the condom. The condom has been proven to be the best way of preventing HIV. So we are going to intensify this campaign even for the next year. So in 2019, we are also continuing with these interventions like condom. Then the last one is the PrEP, pre-exposure prophylaxis. Pre-exposure prophylaxis. Pre-exposure prophylaxis refers to ARVs being given to a risk client, a risk person, a person who perceives himself or herself to be in danger of getting infected HIV because of the nature of their work. So such groups include sex workers. Like I mentioned earlier on, it is more lucrative to have unprotected sex for sex workers because they may get US dollars or better payment. So for such clients, we are now encouraging them to go on PrEP so that they protect themselves. PrEP is meant to prepare oneself against HIV infection. Let me also explain that PrEP, you need to take it a number of days before you engage in sex. It's not like you take the pill now and say, I am getting protected. No, it needs proper management. So this is what we are doing. PrEP has not been rolled out extensively. We are in the pilot phase, but for 2019, we expect now to roll out to all the provinces. But meanwhile, in Masvingo province, it is being piloted. We are working together with our partners, SESHA, and Population Services International to give this PrEP to these clients. So that is to do with the 5 pillars of prevention. Let me also say for 2019 planning, because we are planning for 2019 interventions, this will be the focus NAC will also follow. And this is what UNAIDS, the global body coordinating HIV, has said all countries should focus on. And we are working together because the National AIDS Council is implementing or coordinating a multi-sectoral response to HIV. We are working with a number of partners. So we are working with these partners to integrate programs. We have realized that one of the challenges to go it alone, resources are never adequate. So what we have done is to make sure that we complement each other. We map and say who has what, which comparative advantage do we have. So one organization may say we have these resources for an intervention, but it's not adequate. So the National AIDS Council or another partner can also come in. So we collaborate. For example, in Mwenes District, we are partnering with FHI 360 to scale up what is known as the CAG program. CAGs, these are community groups of people living with HIV who form a group, members living with HIV within a community, come up together, maybe 5, 10 people, and form a club sort of, so that they will send only one person to collect their medicines every time when they need some resupplies. This is meant to cut on costs, on traveling costs. One of the challenges people living with HIV were facing was the issue to do with transport costs, having a burden on them. So this one was seen as the answer to make sure that they save. So if it costs $10 from Chivi to Masvingo to collect medicines, then they contribute maybe 25 cents, 25 cents, 25 cents, and make $10, then send one person. The next time they rotate. That is how the CAGs operate, to ease especially on transport. But the CAG is not only meant for saving on transport, they also provide psychosocial support to each other, so that they have, mental well-being, so that they also give advise each other on some economic activities, some livelihoods, strategies, so that they're able to also take good nutrition. So many activities are happening, so many things are happening within the CAGs. So that is the collaboration we are having, especially in Mwenezi. We are also collaborating with a group called, an NGO called Zandiri. Zandiri is a group of young people, adolescents living with HIV. So from the word Zandiri, it means what I am. So these young people are saying, I am HIV positive. As a result, this is what I am. Accept me as I am. This model of the Zandiri has been seen to be very effective, especially for the adolescents, because it's a peer-led intervention as well, where these adolescents are recruited to become mentors for their own peers. Most adolescents were born with HIV, and the parents, in most instances, are not forthcoming to disclose their status. Some of these children grow up being given medicines and being told by their parents that they are taking medicines maybe for BP or for other ailments, not for HIV. So some of them grow up to 14, 15 years without knowing that they are HIV positive, because the parents are afraid of stigma. The parents are afraid of being pointed at by communities. As a result, this affects the young children. So research done has shown that when these young people realize that they are HIV at a later stage, it would actually affect them emotionally. So the Zandiri model is meant to close this gap. It has been shown that it works, because now these young people now go into communities and encourage each other to disclose. encourage parents to tell their children their status, so that at least they know their status early and they are able to manage their life. And most of them have done very well. Those who accept, they are recruited into these groups called CATS. Maybe we could have heard about CATS. These are called Community Adolescent Treatment Support Groups, CATS, which means the adolescents are also forming a group which is almost similar to the CAG I explained on earlier. But this one is specifically for young people. And these young people will be doing almost the same the same activities, like providing psychosocial support to each other and also encouraging each other to go and collect medicines. So the CATS program in Masvingo so far has been implemented in Mwenezi, Zaka District, Gutu, and Chivi. But unfortunately, for 2019, the NGO which was implementing this program is pulling out, Shandiri, leaving a gap. But we are not saying there's a problem, because as NAC, we are going to provide some funds so that we sustain the program. So for 2019, we are still going to make sure that these kids continue to be operational, because we've seen that it is very effective. Then in terms of challenges, the major challenge we are facing has to do with the cancer screening machines. You know that HIV and the cancer have been seen to be causing a number of deaths, and these cancers and other non-communicable diseases are also accounting for the majority of death. So as the National AIDS Council, we've taken a niche to make sure that we raise awareness within communities, so that people, both men and women, are aware of common cancers, symptoms, and also encouraging them to get treatment. Unfortunately, resources are not permitting to have comprehensive provision of the treatment, but efforts are being made to make sure that more cancer machines are procured. We are working closely with the Ministry of Health and Child Care and also other partners to make sure that this service reaches to our deserving people. I'm sure I've outlined basically what our province is like in terms of HIV. Maybe I can now entertain questions.